So again, when I put it in, I'm going to follow the curve of the teeth and then flip it up so that this is following the curve of the tongue, and it holds the tongue forward and it provides a nice pathway. You see that? How lovely that is? That is quite lovely. But again, it will stimulate the gag reflex, so you do need an altered level of consciousness to use this piece of equipment. The other nice thing about this is that this is completely hollow. So if you needed to suction your patient, you could also use this OPA to suction your patient and get a good, nice, deep suction. Okay? The next airway that we'll talk about is the endotracheal tube. This is a number 7. There's different sizes for different type people. I'm probably a 7. We usually go by the size of somebody's pinky. A small person would have a smaller size, would have a 5 or a 6. A large person, say somebody who's 6'5", would probably use an 8 or a 9. There's a line down the center of it that's radiopaque so that we can check placement. There is a couple open areas. There's some measurements along here that you need to be aware of because we're going to record this when we intubate the patient, where the tube is at the lip line. There's a balloon that can be inflated at the end, that will be inflated, that holds this in place. It's very important that this balloon stays inflated. You can check the pressure by checking this balloon here. It should be firm, but you should be able to move it. It shouldn't be taut. If it is taut, then that means this balloon down here is also too taut and will be causing pressure on the inside of the patient's trachea, and will then cause a pressure ulcer inside there, and that may lead to many different things. But when this goes in, the balloon is deflated. The doctor will probably even use a stylet, and all that does is give the tube some rigidity. So when this goes in, it goes in directly through the mouth. Sometimes nasal intubation is needed if there's a bunch of trauma, but it's usually kind of easier to go in through the mouth. The doctor or respiratory therapist or anesthesiologist will visualize the vocal cords and go down through the vocal cords here. Okay? So it will end up, not that far down, it will end up about right there. We'll then inflate the tube and we will check for placement. Now we check for placement in a couple different ways. First of all, the easiest way to look to check for placement is to look at the patient. Or do they have equal chest rise? Or is it just on one side? Lots of times it'll get intubated into one side. The other thing is we're going to look at the end-tidal CO2. Remember, we used end-tidal CO2 when we did nasogastric tube intubation. And all that is it's checking for CO2 at the end of an expiration. Now, if this is in my lung, will there be CO2 with expiration? You better say yes. So that would be a way to check placement. And we will definitely always get a chest x-ray to confirm placement. We wanted that chest x-ray to be, it's probably going to be portable, and it'll be very soon after placement of the chest or of the endotracheal tube. Okay. It should be a few centimeters above the carina. The carina is where the trachea splits into the bronchus. If it's at that junction, then it's going to stimulate a constant cough, which is not good for the patient. A cough once in a while is good. A constant cough is bad. And then the last airway pause it.